All right, it's 12:35. I'm going to get us started. Welcome, everybody. This is a clinical consultation network. Of course, we do this every Tuesday at 12:30. So glad you could be here with us today. Today, we've got a great presentation by Ben Hudson of Sensory Health. He's going to talk to us about sensory integrated care, creativity, and health equity. I've reviewed an article for this that really explains a lot about what they're trying to accomplish there, I think. And it's really quite impressive. So I'm glad to have Ben Hudson as our guest today. Make a couple of other announcements, and we'll circle back around to Ben here. So for next week, we've got one of our NAD collaborations, and Babs, help me understand. Are we still negotiating our presenter for next week, or
We have Margaret for next week.
Margaret? Simply stated, Margaret.
That's the information I have.
But this is going to be quite impressive with a one name person. I'm not sure I know who this is, but I'm quite certain with that intro, it's going to be great. And then, so that's our fourth Tuesday NAD feature that we have next week, January 24th. Then on January 31st, we've got Marissa Smith Fletcher with Empower Tennessee, going to talk to us about housing resources, such an important topic these days because so many people with disabilities are having a hard time affording things in this housing environment that we're in and finding the appropriate housing for them. On February 7th, we've got my old buddy Adrian. We're not such an impact because we made the statement times we've got 100,000 disabilities across the state of Tennessee, but only a small percentage of those are actually in services. So the rest of the people who might need some things are not currently in services. And Adrian has, through his work, been able to identify a lot of things that people may be able to utilize even when they're not in services. And then on February 14th, we've got Catherine McLaughlin coming on to talk about sexuality education for self-advocates. This is such a key thing within our system that I think people need to understand. So I hope to tune in for us on February 14th. I will be out for a couple of weeks beginning on February 14th. And so I believe I've got Babs and Michelle Bagby who are going to be filling in for me on the 14th and may have to fill in for me on the 21st as well. But I should be back by the 28th for our next NAD collaboration. So that's what we have upcoming on CCN. Next slide. This is today's Get Smart article, which Ben supplied me. Great article here about dental services for people in a sensory environment, sensory adapted environment. So the article today is by Falea et al. And I'll just talk to you a little bit about this on the ensuing slides. Next slide. Successful dental services. So this was some information I got from the intro here. People with ASD often experience difficulties with dental treatment in a regular dental environment. So part of that is not participating in regular preventive dental care, but also not completing dental procedures. They may go in to have a cavity filled, but they won't get it filled because they're not participating well in the process or because the environment is just too difficult for them to participate within. The authors of this study hypothesized that a sensory adapted dental environment, or SADE, will improve their response to treatment. Next slide. So the participants in this study were 50 persons with autism spectrum disorders and at least 2 cavities requiring treatment. The diagnosis of ASD was established using the Childhood Autism Rating Scale, the Autism Developmental Observation Scale, or the ADI, forgetting what that acronym stands, Autism Inventory, accepted for any of those methods were accepted for diagnosis. And in this study, we had 36 males and 14 females. Next slide. So we had a dentist here with over 20 years experience who provided all the treatment. The first session was completed in a regular dental environment. So one where there were really no modifications. It was pretty much a typical type of environment that anybody would go into for their dental care. The second session was completed in a sensory adapted dental environment 60 days later. What we mean by sensory adapted in this circumstance is soft lighting, They played familiar movies, cartoons, or advertisements where the person could see them while they were receiving their dental treatment. They also used a sponge-coated dental turbine drill to minimize the noise affiliated with the dental treatment. And the dentist performing the treatment was basically the evaluator of the success or failure of that treatment. Next slide. Results were the sensory adapted environment was much better for obtaining treatment than were the regular dental environment. So you can see that in this slide where we have basically 38, 39 of the participants were unsuccessful in the RDE part of the study, and 10, maybe 11 were successful under that scenario. Then under the sensory adapted environment, we had 34 people who received the treatment and successful treatment, and that would leave us with 16 who were not successfully treated. Next slide. Just a few little, oh, wait a minute, I missed a slide. Was there not another slide in between? Well, I guess I did miss a slide here, but another slide showed that there was actually a much greater effect for the males in the study than the females. So that was just an interesting finding there, but overall, the results were that it was a significant effect of the sensory adapted environment. Some of the discussion was that there was a small sample size for this study. So having only 50 folks, and especially only having 14 females, we might not have gotten a full picture of what happened with this study and how the sensory environment may have helped. It was mostly males, as I've already said. There were no typical controls. So if they had a control group of typical people who were receiving these services, that might have enhanced the results. And then the dentist who was providing the treatment was also assessing the success of the treatment, which may have been a little bit of a confounding variable there. Although the results were consistent with other studies that showed that sensory adapted dental environments are effective, and it was most significant, as I've already said, for males. And I think that is our Get Smarticle for today. So Ben, thank you so much for sharing that. And I want to welcome you here today. And you're with Sensory Health. You've co-founded Sensory Health. Can you give us a little bit more of an introduction of yourself and what Sensory Health's all about?
Yeah, absolutely. So I'm going to share my screen here in a moment, and I'll kick that off by talking a little bit about what Sensory Health is and kind of what our focus is. But my name is Ben Hudson. I'm the co-founder and CEO of Sensory Health. I am also a CPA and a journalism school dropout. So naturally, now I'm talking to a bunch of medical professionals on a Tuesday afternoon. Really grateful to be here. I do have a similar research study that to the one that you were just talking about, Bruce, that I'm going to bring up during my presentation to give a little more kind of rounded approach to that. I was asked to come up with an interesting fact about myself, and so I guess in anticipation of being a future journalism school dropout, I, for a brief period of time, was a new music reviewer for a local media outlet here in Dallas when I was in high school, and had a press pass and everything. They weren't really I never got paid for anything, so I think they kind of got one over on me, but Janet, I dropped out of USC. There was a question in the chat. I was at the Annenberg School in Southern California and made it 2 years. It was during the economic crash. All my professors were telling me that the industry was dying. And so I became an accountant. And then, over time, I transitioned into this. I also, I did look at U of Missouri. I loved that campus when I was out there. So without further ado, I'm going to go ahead and share my screen here, provided I can still figure out how to do that. And there we go. All right. Bruce, could you give me a thumbs up if you can see that? Perfect. Awesome. So again, my name is Ben Hudson, and I'd like to welcome you all today and thank you all for taking the time to be here. I want to start out by just noting that the fact that, all of you are coming to these events, and especially these events focused towards intellectual developmental disabilities, helps show all of us that kind of the medical industry at large is realizing that more equitable care can be achieved. And so I want to personally thank all of you for your commitment to being a part of that change. Without folks out there providing services that this population needs, we would never make progress. And so I just want to take a brief moment and hope you all understand just how important the work that all of you are doing is. And thank you again for having me here today. I'm going to start by telling you a little bit about what Sensory Health is. I co-founded the company in spring of 2021, so we're just under 2 years old. And our mission is to reduce the burden on patients and families by being able to kind of certify clinics as sensory friendly. I'll get into a little bit around the cost reduction side of this a little later on. But really what we want to do is be able to give folks who don't currently have medical and dental homes access to that, right? If I want a dentist, if I want a doctor, all I have to do is Google dentist or doctor in whatever city I'm in, and I know that that provider is ready for me. That's not the case for folks with IDD and folks with sensory needs, and so that's the barrier we're really trying to attack. And we do that through a combination of sensory integrated design, practitioner education, training programs like this one, and then over time building out a directory of sensory friendly certified providers to be able to give patients, their caretakers, their family members that extra level of assurance when they're going out and trying to find a provider. Excuse me. Now, to start out with, one of the things that I have noticed in having these discussions over the past couple of years with various medical practitioners is that not everybody has a strong or really, foundational understanding of what sensory processing really is. And so we're going to start out with kind of generally how that flows. And there's not going to be a quiz on this, but the important thing to understand here is kind of the high level flow of how this process functions across the board. So in a generalized sense, the first thing that always happens is there's a stimulus that's received. That stimulus then goes through the sensory transduction process, which converts that stimulus, that signal, into neuronal activity. That then triggers the peripheral nervous system, which controls both the autonomous and somatic functions, which is to say the involuntary bodily functions like sweaty palms, increased heart rate, and also the voluntary responses, which are, the things that you're aware that you're choosing to do, like leaving the room if it's too loud. That information then feeds into the central nervous system, where the brain processes and assigns meaning to those signals, and then determines emotional response and regulation. Now, after all of that has happened, a behavior occurs informed by all of those previous steps. And this is the general schema that applies to across sensory modalities. So whether we're talking about sight, sound, taste, smell, body awareness, like body positioning, like in dentistry, for example, being reclined in the chair, that's, that impacts both the proprioceptive and vestibular systems. And so in any circumstance where sensory stimuli are being received, they will generally flow through this same process. Now, for people like me who do not have sensory needs, there are obviously sensory inputs that I don't prefer. One thing that I like to ask folks if I speak at conferences or things like that is, hey, are there any foods that you won't eat, not because of the taste, but because of the texture? A big one for me is cottage cheese. I used to eat it as a kid, and now I just can't handle the idea of it, even though it tastes fine. I just can't get over how it looks, any of that. That's a sensory preference, right? That is not preventing me from achieving equity in any area of my life. There's nothing that requires me to eat cottage cheese to get through the day. However, for somebody with sensory processing disorder, which applies across a variety of other diagnoses, that's not how that works. And so it's important to note that for autism spectrum disorder and other developmental disabilities, for ADHD, for PTSD and other anxiety disorders, that there are quite literally physical and chemical differences in the way those individuals process, perceive, and assign meaning to sensory inputs. And so another way to look at this is that while one person who is, call it typically developing, and one person with autism spectrum disorder, if they perceive the same sensory stimuli, there's no guarantee that that stimuli will be processed in the same manner, because individuals with ASD and other IDDs have, again, physical differences in the way those inputs are processed. And so one thing that I always like to highlight here is that behavior and stimulus are not marked as altered on this slide. And that's because everybody's going to receive the same stimulus regardless of diagnosis. And the behavior is really not a part of the diagnosis or the sensory processing differences. And I think this is a really important point, because the behavior is a reaction to the input based on how that individual processes the sensory stimuli. And so if we are focused on treating the behavior, we've really already missed the opportunity to make a change that could have a better outcome for that individual. Said a different way, the only thing that we can change without pharmacological intervention is the stimulus. And so if that stimulus is a serious trigger to somebody, the only way to prevent, that stress, that behavior, is to adjust the stimulus. And a recurring theme through all of this is the importance of being proactive rather than reactive. Again, if we're focused on treating the behavior, we have long since missed the opportunity to prevent that potentially adverse reaction from arising. The way that a person processes sensory information is intrinsic to that individual. It's a difference in the way the brain actually functions. And so while individuals with sensory processing challenges may have developed coping strategies which help them manage in stressful situations, these individuals are shouldering an outsized burden by trying to fit into a world that does not accommodate them. And so by altering the stimulus and being proactive to a person's needs instead of reactive to their behaviors, we can better support individuals with sensory processing challenges and lessen the risk of an adverse reaction. And I'm going to sound like a broken record, but if we create an environment where the stimulus does not trigger that negative response, we have a significantly better chance of a collaborative experience with that patient, regardless of the setting.
And let me just ask a quick question here, because
Sure.
this is partly coming from the perspective of the sensory processing theory, but would it not also be possible under these circumstances to teach someone to respond differently to that stimulus, even though that's having this sensory processing, they're having this sensory processing difficulty? Maybe try to work with that a little bit and explain a little bit about how
Yeah.
that.
Yeah, absolutely. So that's a really good question, and that honestly is a big part of the reality of, delivering healthcare to somebody with sensory needs. There is essentially no chance when working with a patient with sensory needs that that person has had only positive experiences, right? And so if you take somebody who has had prior traumatic experiences in a dental or medical environment, there is absolutely a large component of desensitization, right? Getting that individual comfortable with the surroundings, explaining why the things are the way they are. So for example, there's always things that we can't change, and I'll speak to this a little more later. If somebody needs a shot, I can't ask a doctor not to use a needle, right? If somebody needs a cavity drilled, I can't ask a dentist not to use a drill. What we can do is provide clear expectations, explain what the sense is going to be and why it needs to happen, and work with the patient to kind of prepare them better. And so it's sort of a two-pronged approach of the environment can become both, part of your treatment team instead of working against you, and better preparation and kind of process changes can help prepare the patient so that those triggers aren't the worst kind of trigger is one we don't see coming, right? And so the better that we can explain things in advance and kind of prepare that individual, the better likelihood we have of them being able to kind of self-regulate in a potentially stressful environment.
Thank you for that.
Sure. And so a lot of my presentation here is focusing on dentistry for reasons that I'll get to in a couple slides here. But I wanted to just kind of point out that, dental anxiety, medical anxiety, difficulty receiving medical care is not exclusively limited to individuals with IDD or limited to individuals who have explicit sensory needs. And so this was a study from the American Journal of Occupational Therapy where they asked 202 typically developing children and their parents about their dental experiences, really from a sensory standpoint. And so, again, everybody has these sensory preferences and is physically and emotionally influenced by their environment. But, you can see here that roughly a quarter of typically developing children responded that the dental drilling was particularly stressful, created discomfort and fear. Feel of the instruments, just under 20% reported that that created discomfort and fear. And just under a quarter of the parents would classify a dental visit as moderate to extremely difficult. And this is for, typically developing children who have the access and, providers who are, kind of willing to work with them. Dental anxiety is not an uncommon thing. And so I do empathize with dentists. Everybody is nervous going to the dentist. I've talked to so many dentists who don't like going to the dentist. It's not an uncommon thing. But when they expanded that study and surveyed just under 200 autistic children and their parents, we can see those typically developing results there. But for the ASD population, half of them responded that the dental drilling was an extreme discomfort. Nearly 3/4 responded that the feel of the instruments. 25% responded to the feel and taste or smells and tastes present in the environment. And half of the parents surveyed considered dental visits moderately to extremely difficult. That's half of parents for something that we know is such a critical component of whole body healthcare, right?
You have to do it a couple times a year. So
do I?
That's a lot of people and a lot of appointments.
It's a lot of people. And so when we talk about, who is most affected by sensory needs, the most significant barriers are those with autism spectrum disorder and other intellectual developmental disabilities. But other patients significantly impacted include those with ADHD and anxiety disorders, particularly PTSD. Not mentioned on this slide, but absolutely worth calling out here is that individuals with memory issues or Alzheimer's, dementia, and related diseases, there are significant sensory components that come along with that, especially at the beginning of that process when the memory is starting to fade. People start to get feel very threatened by their environments. And so being in that space can become kind of a threatening place. And so ultimately, unaddressed sensory needs cause decreased access and quality of healthcare, leading to poorer outcomes for these populations. And this is not a small sliver of the population either. Just under 27% of US children could be considered to have sensory needs. And there are roughly 25 million children in the United States. So that's like 6 million kids. And in 2019, a National Health Interview Survey found that just under 16% of US adults met criteria for generalized anxiety disorder. That's 30 million adults, right? And so while there exists a very, a wide spectrum of sensory processing challenges, we're talking about very significant portions of the population who, even if these aren't, the kind of barriers preventing them from getting healthcare at all, making these kinds of changes, these environmental adjustments, can significantly improve their patient experience and their outcomes. Poor oral health care, as we know, leads directly to worse overall health conditions, as systemic gum disease can lead to diabetes, heart disease, and other serious conditions. And beyond the health risks is the simple truth that everybody deserves quality dental care and to have a smile that they're proud of. That holds true across disciplines. Obviously, like I've mentioned here, per Project Accessible oral health is the single largest unmet healthcare need for individuals with disabilities. But these kinds of barriers exist across specialties and across delivery types.
Yeah, we see this in doctors' offices, as well as just other more idiosyncratic types of patients where people with traumatic stress are affected. So you think this extends to those other populations just as much as the ASD population?
Absolutely. Yeah, absolutely. I think that a lot of what we call dental anxiety can really be traced to sensory stress, right? Basically, if you think about going to the dentist, there's essentially nothing that happens in that environment that exists in any other environment, right? You're in a weird chair, there's stuff in your mouth, there's a spotlight in your face. Like none of it is normal from an environmental standpoint. And so a lot of that fear comes from that feeling that your environment is no longer a safe place to be, where you have any kind of control or agency. And add that to the fact that it's uncomfortable, right? That obviously
It's all
doesn't
right
help.
up here in your face too. It's
Right.
not, even with a medical exam, those are.
Bruce, you're breaking up. I can't really hear
Oh,
you.
I'm not sure if you could understand what I said, but
Yeah, I think I can restate a little bit. Yeah, I mean, in dentistry, somebody's hand, like, it's very close, right? The personal space in any kind of medical environment, personal space becomes sort of non-existent. Add to the fact that most people aren't going to the doctor or dentist outside of, regular cleanings unless they're in some sort of discomfort. And so add, a pre-existing pain or discomfort on top of sensory issues, you're going to have a very potentially difficult time. And the reason for that is the concept of sensory overload. And the analogy that I like to make here before I kind of dig into it is that imagine you've got a glass of water, and for each, sort of stressful sensory input, you pour a little more water into that glass. Eventually, that glass is going to overflow. And once it does, you're not putting the water back in. Doesn't matter how hard you try, that water's not going back in that glass. And so you can think of sensory overload in kind of the same way, where there's this stacking effect where each additional sensory trigger kind of creates this increased sense of stress. And at a certain point, we experience behaviors that people might call, adverse or maladaptive or whatever word they want to assign to them. But essentially, it's a reaction to becoming overwhelmed by the environment and not having the ability to kind of self-regulate when faced with that level of stimuli. And so that's really kind of what we try to focus on, is using sensory modulation to help achieve and maintain ideal sensory stimulation, which really prevents the individual's self-regulation strategies from becoming overwhelmed. So in that way, an accommodating environment that has this kind of sensory focus can become a part of the treatment team, as it were, by working with the patient to support their own ability to self-regulate, kind of empowering that individual, the patient, to feel that agency in their environment by not viewing it as threatening or hostile. Now, there is, a caveat here that sensory modulation works best when we have not yet hit that overload point. And so if you think about getting to that crisis stage, the positive impacts of sensory modulation become significantly less effective. And so in an appointment setting, in a medical setting, once that overload occurs, the likelihood of completing that appointment without either imparting trauma or risking injury to patient or provider, that it drops significantly. And so one piece of this for working with this population, is that it's important to identify when the appointment should be stopped. Respecting that a crisis overload state does not mean just kind of pushing through because the patient's already there. It may be inconvenient, but there are definitely cases where it is better to reschedule that appointment than to risk additional trauma or injury. Folks come in with negative prior experiences, bringing that trauma with them, and trying to push through is simply not going to end well. We need to understand when that threshold has been reached, which is why, again, being proactive instead of reactive, focusing on preventing sensory crisis through sensory informed care rather than focusing on managing the crises after they occur and using potentially more traumatic measures such as restraints, sedation. I do want to note that there is definitely a percentage of patients for whom restraints or sedation may be the proactive approach. There are always individuals who may need that extra support, who may need, some sort of medication to be able to get through that event. But the majority of individuals are able to receive in-office care if they feel comfortable, safe, and taken care of. Now, this doesn't mean that just because you have a calm patient that you should deviate from any previously communicated treatment plan, but just to show that you can use, various tools to create these types of environments. Another big issue for this population, specifically the population with intellectual and developmental disabilities, is the stigma associated with those diagnoses from providers who don't necessarily understand what that means. And so this was a 2018 study with interviews with parents of autistic children, talking about their experiences at the doctor and the dentist. And so this one parent said, that she was getting a lot of judgment from the provider for her son's dietary habits. And she was like, look, we faced a lot of what does he eat? And I'm like, sometimes all I can get him to drink is a milkshake. I don't want him to have a milkshake. I know that's not good for him, but I need him to eat something. And so it's critical to remember that we don't know everything that's going on in that patient's life. We don't know everything going on in that caretaker's life. And so, while some of these patients may have difficulty with oral hygiene at home or, dietary issues, the ability to establish that trust with the patient and meet people where they're at goes a long way, right? Simply receiving that individual without stigma, without judgment, and knowing that the person who is there with them is absolutely doing their best. And similarly, it's not just about the appointment setting either, right? If you think about a healthcare appointment, that appointment really starts the second that person walks into the building. And so, in this this parent quote, the waiting room is a whole separate thing. It's almost like having an appointment in its own right, going and sitting in the waiting room. That's a thing. And then you go and do the dentist, which is another big thing. And so, this individual continued on to say that she felt particularly guilty and full of shame being in the general waiting room because she knew that her son's stress and anxiety could be felt by the other children in the room. And so she felt responsible for, creating this sort of stressful environment, which obviously was not her fault. But there's that additional level of concern about sitting in a waiting room, filling out paperwork, trying to do a bunch of things at once. And so, one thing that's easy to do, and pretty much everybody was doing this during the height of COVID, can you let the patient wait in the car until the room's ready? Is there another entry point into the building that bypasses the main waiting room? This is one of those areas where you can get a little creative and be flexible. There's no law that says people have to check in the same way, right? If you have a patient who is going to have a significantly better experience by being allowed to wait until that room's ready and then just go straight in, it's not hurting anybody, right? And the important thing here is just asking what works for the patient, asking the patient's caretaker what works for them. The biggest thing, the key takeaway from everything here is being proactive. Quote, this was the researchers' findings in this study. Stress was alleviated in instances where the dental team were involved in helping the families prepare by providing information on what to expect from their visit, collecting information about their child in order to make environmental adjustments, and keeping contemporaneous notes so that parents don't have to repeat the same information every visit. And I know for me personally, I am very tired of trying to remember what year I had chest surgery when I'm filling out pre-appointment paperwork. I have filled it out 1,000 times, and it really doesn't seem like it matters anymore. But being able to be more proactive about getting that information, because at the end of the day, the patient, their family member, whoever it may be, that individual is the expert in what the patient needs to feel accommodated. And we would be remiss not to take advantage of that resource.
Speaking of that, Babs, you want to process?
I can't really hear you, but I have.
Yeah, Bruce, you're cutting out quite a bit.
I've got some questions that have been submitted. Can I go ahead and ask one of those?
Yes.
Please.
Okay. One of them is, what tools or assessments would you recommend to identify an individual's sensory deficits or adversives?
So really, I would stay away from trying to kind of identify or specifically diagnose anything. So one thing that we've done is we've developed a kind of pre-appointment questionnaire. And there's a couple things that we like to focus on. One, has the patient had a positive experience in this medical setting before? If so, what do you think worked? Has the patient had a negative experience in this kind of setting? If so, what was the issue there? And then basically kind of going through the high level senses and kind of rating sensitivity from the patient's standpoint. So you scale of 1 to 10, 10 being the most sensitive. How reactive is the patient to light, sound, et cetera, et cetera? I'm sure y'all are all aware sensory processing disorder is not technically part of the DSM anymore. I could go on that for a very long time, but basically the approach should just be, it's less about kind of what the diagnosis is and more about the tactical issues themselves. So what are those triggers so that we can kind of prepare to avoid those.
Thank you. Okay, another question we've got is, what would you recommend for growing competency for practitioners with regard to sensory competencies?
Honestly, realizing that you're already seeing these patients, right? So there is an element of lack of confidence. There is an element of not feeling like there was proper training in place for these things. There are a lot of resources out there. We're just one of them. But, everybody who sees patients is currently seeing patients with sensory needs, whether you realize it or not. And so one thing to take away from this is that, and we'll get into kind of what the accommodations look like in the next few slides here, but that this kind of approach has positive benefits kind of across the patient population. And so what you'll end up with is an environment where your neurotypical patients, your patients without sensory needs, have a more positive patient experience because the environments are just nicer to be in. Nobody likes being in a medical environment, but you're also able to expand access to a population that is currently experiencing a significant barrier. And so with regards to, practitioner confidence, the actual delivery method of healthcare is no different, right? The things to focus on are how you communicate, kind of understanding that patient's prior experiences, and then being able to work in kind of an adaptable environment. And I'll get into some more specifics on that here in a couple slides.
Well, those are the questions I've gotten so far, so we can keep rolling.
Sounds good. So I want to mention real briefly kind of the history of multisensory environments. This is going to be a real quick overview, but in the 1970s, the De Hartenberg Center in Holland, which was an inpatient sanitarium at the time, right? They wanted to do something for their patients that could be more interactive. They realized that a lot of their patients just didn't, they didn't have much to excite them or kind of engage with throughout the day. And so they put together this kind of sensory fair and came up with this idea of a snoozling room, which is a combination of the words to sniff and to snooze, reflecting that there was both stimulating and soothing sensory features in a multisensory environment. That snoozling room has now become what is called a multisensory environment, or an MSE, and that multi refers to having kind of both multiple sensory modalities and having both stimulating and soothing features for varied sensory needs. And a lot of the work in this area has come through the field of occupational therapy. And we have a partnership with AMSI, the American Association of Multisensory Environments. And so I want to specifically call out Linda Messbauer, who was a founding member of AMSI and opened the first United States-based MSE at LifeSpire in New York. Linda unfortunately passed away a couple years ago, but we remain grateful to her contributions to the field. And I know that when I say multisensory environments, everybody tends to have an idea of what that looks like in their head. There's the big flashy equipment, kind of some of the things that are in this here with the long fiber optic cables, big bubble tubes. These are really expensive pieces of equipment. And so one thing that we really try to focus on is the fact that you don't need to do that to have a sensory modulated environment. This is just a handful of multisensory environments where individuals have kind of taken it upon themselves to do things. And so in that top left corner, basically that's a school that had a couple $100s and a lot of stickers, and they decided to build kind of a sensory pathway between classes so that there were these more engaging ways to get from room to room, so that their patients who needed to stim or who had kind of sensory anxieties could get some of that energy out in a controlled way in the hallways. A lot of these are just folks doing what they can in the spaces that they have to try and make things more accommodating. And so to go back to, this concept of the sensory adapted dental environment, there was a 2015 study out of the University of Southern California between the School of Occupational Therapy and the dental school, where they basically did kind of the same thing. This was another small sample size, but they had 22 typically developing and 22 autism spectrum disorder patients. Each group had 2 appointments spaced 3 to 4 months apart, one in a regular operatory and one in an adapted environment. You can see what they used for the adapted environment there, dark curtains, a lamp on the curtain to give indirect light. The dentist utilized a headlamp instead of the bright overhead. slow moving kind of aurora on the ceiling. And then this butterfly wrap, which was something they came up with that was basically a non-constrictive form of restraint where it was sort of patient directed. So as they felt comfortable, they would kind of, bundle themselves up in it. And they were really trying to study both patient experience and quality of outcomes and the potential for cost savings. And so for patient experience / quality of appointment, they used electrodermal data to measure stress responses in both environments. And so it was a combination of kind of physical responses through these electrodermal sensors and patient reported information using a pain intensity scale and a sensory discomfort scale. Excuse me. The electrodermal data, activity data, showed reduced stress response in the adapted environment for the ASD population. And the patient reported information, the ASD group reported significantly lower pain intensity and significantly lower sensory discomfort. And there were similar results for the typically developing group, although obviously less significant because those individuals weren't starting from as extreme a place of stress. But we still saw reductions in reported pain intensity and sensory discomfort and in the electrodermal stress data. Now, on the cost saving side, they were really looking at two things. One, the length of appointment, and two, the number of people that needed to be in the room. And so on the, from the length of an appointment side, the exams took about 35 minutes instead of 30 in the adapted environment, but the dentist did report being able to do much more thorough cleanings. And so that's one where we would need a larger data set to really see if that, length of appointment holds true over a significant period of time. Additionally, the number of hands required in the room dropped. So whereas previously in the, the control environment, it was typically a dentist and 2 hygienists in the room to kind of keep the patient calm. In the adapted environment, they needed, 1 fewer individual. And so from a cost standpoint, needing 1 less person in the room, that frees that person up to see other patients, right? There's a lot of potential benefits there. And then really importantly, again, small sample caveat, but none of the ASD patients required pharmacological intervention, even though some of them did have a history of receiving general anesthesia in a standard, preventative dentistry setting. And that's really important because while there are always going to be people who need some of that extra support, general anesthesia is not a zero-sum game, right? There are individuals, not very many, but more than 0 is too many. There are individuals who die in hospitals every year with IDD as a result of simply receiving general dental work under general anesthesia. Again, it's not a lot of people, but the fact that it's more than 0 is concerning, right? And so what can we do? What are some general guidelines? What do some of these look like? What do some of these things look like in practice? Sorry, I lost my window there. So general guidelines, avoiding bright direct lighting, favoring indirect color variable lighting, avoiding fluorescence, which I have yet to meet a person who has defended the integrity of the fluorescent light, using the dental headlamp if you can instead of the overhead, or if you need that kind of additional light, making it focused at the location that you need it to be instead of kind of generally everywhere. Projecting an aurora style light either onto the ceiling or wall or kind of wherever you'd like the patient's focus to be. Giving somebody something kind of soothing to kind of lock onto makes it a lot easier for that person to kind of sit still and feel supported by their space. And so we recently worked in a dental clinic in Jackson, Michigan, and you can tell, in that left photo there where it just looks like a standard dental operatory, we've already put in all of the modifications that we did, but looks like a standard operatory. The one thing you can't see in these photos, I'll show you in a couple of photos, is we did put some additional soundproofing in the ceiling because drop ceilings have a lot of echo effect. But, a simple LED strip behind that counter there. We have this projector that puts, stars and aurora onto the ceiling. It's not super obvious, but there's a heavy base iPad mount next to the chair there because if you've got a show or something that provides comfort, as long as it's not interfering with the appointment, there's really no reason not to take advantage of that. And then a white noise machine that provides, some basic soothing sounds. From an auditory standpoint, again, dampening the extraneous sounds as much as possible, demonstrating instrument use, so that kind of tell, show, do approach to, any process. But, if it's the dental drill, for example, using it in the dentist's hand in the chair to kind of give that patient a sense of what it sounds like, using it briefly in the mouth, and then doing the actual work. offering noise canceling headphones or head plugs, using a white noise machine. If the patient has music that is going to be soothing to them, allowing them to bring that in, provided it's not disruptive to the flow of the appointment. And so, some of the things that we typically do are, this is a very quality photo of the inside of a drop ceiling where I've put in these sound dampening panels, and having headphones available, basically doing what we can to reduce echo, reduce extraneous surprise noises, right? From a tactile standpoint, tactile is a very broad range. And so anything, think about informed consent, right? Anytime we are going to touch the patient, explain why, explain what this procedure is and why it's necessary. Just describe the sensations before using the instruments. If you're using just like a reflex check and hitting somebody, and then you just explain like, hey, this is what this is going to feel like, and your leg might do this. Just preventing surprises, setting clear expectations. These are the kind of things that are beneficial for everybody in a medical setting, but are very, very important when you're working with people with sensory needs and intellectual disabilities. Specifically weighted blankets, dentists do have a little bit of an advantage here because every operatory's got an X-ray vest. X-ray vests are great, right? They're essentially a super easy to clean weighted blanket that is already made to fit on a person, right? Providing that deep pressure stimulation. I have a weighted blanket. It is my favorite thing that I own. And being able to provide that level of comfort in sort of a patient-directed way. And additionally, speaking to kind of patient histories, has there been previous restraint use? There was an interview, a focus group that I was reading where this this woman and her son had become very comfortable with a certain dental hygienist, and he had had terrible experiences with papoose boards and restraints in the past. And so they had done all this work to get really comfortable with this specific hygienist. The day of the appointment, that hygienist was on vacation. Nobody from the clinic had reached out to let the family know. And when they got there, the the hygienist who was working that day was already preparing the papoose board in the operatory. And so the second they opened that door and the patient saw that, it's game over, right? They had a huge stress response. They had to leave and reschedule. And all of that could be so easily avoided with just a quick phone call saying like, hey, we know that you work with this individual. They're not here today. Can we find a different time? Just, again, understanding that the person who comes in has a whole life that they experienced before they got there, and they're bringing that in with them. Again, I've said this a lot, but expectations can greatly influence sensory experiences. There's, an analogy I like to use here. Imagine there's a brand new, Michelin rated restaurant in town. The only thing you know about it is that the food is incredible. And so you've got a special occasion you want to celebrate. You're going to go to this nice, fancy new restaurant. You're really excited. And when you get there, you walk in and it's lit like a Home Depot, right? So you walk in, it's got 30-foot ceilings, aggressive, bright warehouse lighting. It does not matter how good the food is. You're not going back to that restaurant because the experience is so far removed from your expectations that it's going to have a serious impact on your ability to enjoy that event. And that's kind of what we're talking about here. Having clear expectations goes a very long way. And so asking patients and caregivers how they best communicate, explaining procedures and steps to provide context. One thing that we really like is having a whiteboard somewhere visible where the patient can see it and kind of writing out the high-level steps of the appointment. Because everybody, regardless of communication ability or cognitive ability, more or less understands progress through a list. And so having that kind of anchor point where the patient can just glance over and say to themselves like, okay, we're halfway through, this is going to end, right? It gives people an end point that has real value. And, like we mentioned earlier, waiting rooms can be very chaotic environments, which increase that individual's stress level and fight, flight, freeze response before the appointment even begins. This is a photo of, we had the opportunity in that same dental clinic to kind of repurpose a storage room as a sensory waiting room. And we actually heard from them recently that they had a patient who was having a really difficult time in the operatory. And so they took that patient into this waiting room. And after a couple minutes, they were able to actually just apply the fluoride varnish in this room without needing to go back to the operatory. And so if you have the ability to dedicate a space and make it sensory inclusive on the waiting room side of things, that really supports this population. And additionally, I did get this feedback a lot too. The staff were starting to argue over who was going to get to use the room during their lunch break, because it does also provide that additional level of kind of, having that meditative space that you can use throughout the day.
Ben, what
And the
would
last
you
thing,
say to a provider who doesn't have the ability to adjust their waiting room?
yeah, so that obviously is a real thing. Not everybody owns their waiting room. People share space. And so, in that, I go back to what I mentioned earlier, where if you don't have the ability to kind of make adjustments in your waiting area, there's a couple options. One, is there an unused space in the actual clinical area? Like in this example, there was a file room that they weren't using anymore. But outside of that, can you let the patient wait in the car until their appointment's ready? Is there a separate entrance? I recently visited a clinic where they had kind of a back door that was right next to a quiet operatory. And so that was, a way that they could get patients in without having to go through the main room. But just, being flexible with how the patient flow works, right? Because the waiting room is a big issue. I was talking to somebody who had done a bunch of work at a hospital to really upgrade their ER from a sensory standpoint. But you got there, and to get to the adapted ER rooms, you still had to walk through the main emergency room lobby. And emergency room lobby is a sensory nightmare. And so, having that whole holistic approach of, okay, how is the patient going to get from their vehicle to the exam room in the least intrusive way possible, right? What are the areas that we can adapt? And if we're limited on what we can do, providing those over-ear headphones, sunglasses, whatever it may be, maybe to them while they're in the car to kind of better prepare, or have the parent, patient, caregiver, whoever it is who's bringing them, kind of have those things in mind before arriving, so that they can kind of preemptively be ready for it. Another area, and that feeds into what's on this slide here, social stories can be really powerful things, from an expectation standpoint. So even before the appointment begins, patients and caregivers can benefit from informed providers and knowing what to expect. The social story, very simply, is a 9 to 12 picture overview of any kind of process. It can be for brushing your teeth, for taking your medicine, for taking a shower, and also for going to the doctor. And so being able to see the people they will interact with in the environments they will be in, it helps make that connection when that individual gets to that space, to say, I've seen this before. It wasn't threatening when I looked at it. It might be safe now. It's just having that set up in advance can really provide some benefit to the patient with sensory needs. And then the last thing I'll say, because I know we are running out of time here, is that if you had a patient who was allergic to penicillin, there is no circumstance under which you would see that patient without knowing that. And we really believe that if you have a patient who has sensory needs, it's the same idea, right? If you have a patient, say, in a dental setting, if you have somebody that in advance is extremely sensitive to certain flavors of toothpaste, simply don't use them, right? There is information that we can keep in patient records, and this is something we're working on, kind of integrating our patient questionnaire into EMRs, but keeping those accommodation needs top of mind, again, to be proactive rather than reactive. And that pretty much sums it up. That's my, our general email address there. If anybody has any questions about anything, feel free to reach out there. Babs has my personal email as well, and I'd be happy, for you to share that with anybody who asked for it. Our website is www.sensory.health. And I say this every time I speak. I love talking about this to anybody at any time, in any venue. So, if there are any questions, please don't hesitate to reach out. I'd be happy to have a conversation.
Thank you so much for being here today. I know Dr. Davis's microphone isn't working, so I guess I'll be the one to close this out. I can't remember what you usually say. We see you every week. Can you do it? There
I'll try.
we go. You're working great now.
Yeah, now you sound great.
Okay. Well, thank you so much, Ben, for being here.
Absolutely.
I did have one other question that was burning a little bit for me. How do people access this service that you folks offer?
So we try to work directly with providers. So our, Yeah, so from the patient family side of things, we want to be a resource and be able to kind of answer questions and point people in the right direction. Like I mentioned, over time, we are building out that kind of directory side of things, but all of that will always be free to access for patients, families, any of that. Basically, like, I don't pay to find a doctor who can treat me, so why should anybody else? And so we work directly with providers who are interested in this kind of stuff to deliver training modules, make environmental recommendations, and build some of these additional tools like social stories and our kind of pre-appointment questionnaire. So we do partner directly with the provider side of things.
Does that extend beyond the state of Texas then?
Yeah, I actually have no providers in the state of Texas that I work with, and if we want to talk
Okay.
about the state of disability care in Texas, we're going to need another couple hours and something stronger.
Well,
That's a late at night conversation when you can really just let it rip.
yeah. Well, and maybe we'll get into that at a later time. But listen, I really appreciate you being here. And this has been a fantastic presentation. I think people need a lot of information about this to try to help people have more pleasant experiences with their healthcare and particularly with their dental care. So
Absolutely.
thank you so much for being here. And thank
Thank
you
you
all
so
for
much
being
for having
here.
me.
We do this every week at 12:30. So join us again for the Clinical Consultation Network. See you next time, folks.
Thank you.